Hi everyone. Today we're going to be discussing recurrent aphthous stomatitis, also known as mouth ulcers. So recurrent stands for something which may occur repeatedly, and aphthous stomatitis are discrete areas of ulcerations which are almost and always painful. So an interesting fact about this is that women are most commonly affected as compared to men. And this has seen to reach a peak in the early adult life. Now we're going to look at some of the etiological factors which may be involved. So it has been seen to occur in some allergic conditions. Also, it may be associated with infections like streptococcal infection or viral infections. Stress is one of the major contributing factors to recurrent aphthous stomatitis. GI disturbances like the celiac disease or vitamin B12 deficiency may also be associated. Sometimes it just may be genetic. Hematological disorders like neutropenia may also be associated. So this is interesting. Smoking cessation causes a decrease in the keratinization of the oral mucosa, which in turn makes the oral mucosa more prone to ulcerations. Trauma is a very important factor as well. Sometimes when our immunological host defensive systems are low, the recurrent aphthous stomatitis may occur. And last but not least, some hormonal imbalance may be associated as well. Now we're going to move on to the pathogenesis. When an etiological factor comes in, the T-cell mediated cellular immunity is activated. This in turn activates a complex. This complex is of the native T-cell and the antigen presenting cell. So the native T-cell presents its receptor to the antigen of the antigen-presenting cell. This complex causes a production of cytokines. These cytokines are tumor necrosis factor alpha. Now, these cytokines are going to trigger a production of cytotoxic T-cells. These cytotoxic T-cells are now going to produce substances which are going to be attacking and destroying the oral epithelium, thus causing an ulceration. So there are three types of aphthous ulcers. Number one is the minor aphthous ulcer. Number two is the major aphthous ulcer. And number three is the herpetiform type aphthous ulcer. So the minor aphthous ulcer. Minor aphthous ulcer is seen to last for about 7 to 14 days, and there are typically 1 to 5 lesions. It measures between 3 to 10 millimeters. And clinically, the lesion, when we look at it, it is surrounded by a red margin. We call it a red halo margin. And there is a yellowish floor. Clinically, days before this lesion appears, there's going to be burning, itching, and stinging. And there's going to be no scarring, which is going to differentiate it from the other types. The most common locations that we see are the labial mucosa and the buccal mucosa. Some less common sites are the mucobuccal fold, the floor of the mouth, ventral surface of the tongue or the undersurface of the tongue, and the soft palate. So now we're going to talk about the major aphthous ulcers. The major aphthous ulcer lasts for about more than 30 days, and the onset is after puberty, and it may continue to about 20 years or more. Now we're going to see some complications. Clinically, it may lead to scarring, which was not present with the minor, and it may lead to restricted mouth opening. Now, when we look at the major aphthous ulcer clinically, we are going to find that this over here, the picture shows us that this ulcer is present on the soft palate, and it is a large, deep, irregular ulcer. This ulcer may be about 1 to 3 centimeters in diameter. The number of lesions may vary from 1 to 10, and it may take about 2 to 6 weeks to heal. So the most common sites where we may find major aphthous ulcers, these include the soft palate, the labial mucosa, and the tonsillar fossas. Now we're going to look at the herpetiform kind, and we're going to be able to differentiate it from the other types. So the herpetiform type, this has seen to occur anywhere in the mouth. There is no specific place. They may measure between 1 to 3 millimeters in diameter, and in one occurrence there may be up to 100 lesions. It occurs in early adulthood or late, and it heals within 7 to 10 days. Clinically, when we look at it, there may be numerous pin-held ulcerations which may coalesce into a larger ulceration. Now we're going to look at the histopathology. This is a picture of the slide of the ulcer. This is how an ulcer would look under the microscope. We can see that there is an evident break in the epithelium. We can also appreciate some dilated blood vessels, and there is some apparent infiltrate of the inflammatory cells. So for the diagnosis, to be able to correctly diagnose these ulcerations, we need to take a good history of the patient. And also we need to clinically examine the patient to see the clinical features which are going to help us differentiate between them. So to treat the Aphthous stomatitis, we need anti-inflammatory medication. For that, we are going to prescribe corticosteroids. In that, there is hydrocortisone hemisuccinate 2.5 mg. These are allowed to dissolve in the mouth 3 times a day. Triamcinolone dental paste also sticks to the mucosa and forms a protective layer. And some salicylate topical preparations are available in the market which are going to help relieve some pain. We also need some antibacterial infection to prevent any superimposed infection. For that, we will use tetracycline mouth rinses, which can be given thrice a day for 2 to 3 minutes. These are going to reduce the severity. Chlorhexidine mouthwash 0.2% is used thrice a day as a mouthwash. Now, to put our knowledge into practice, we're going to see that we have a patient in our clinic, 28-year-old, and she has burning sensation in the lower lip for the past week. She also tells us that this has been slowly enlarging and is now painful. When we take her history, she tells us that this has been going on for the past 1 year, and it occurs whenever she has an exam, and it takes weeks to heal, which makes her difficult to be able to concentrate on her studies. So when we look at the lesion clinically, we see that there is a large, deep ulcer on the lower lip. So now we're going to see what things are going to help us diagnose and differentiate the different kinds of ulcers. So when we look at the history, she tells us that this has been going on for the past 1 year. So we can see that this has a pattern. We also see that this is clearly stress related, something which is related to her exams. Also, there are no other lesions on the body, which helps us differentiate it from any other immunological disease. When we clinically look at it, there is a large, deep, irregular ulcer. All of this helps us to diagnose it as major aphthous ulcer. For the treatment, we are going to prescribe anti-inflammatory to reduce the pain and aid healing. And just like we discussed before, some antiseptic mouthwash to prevent any superimposed infection. So that was it, guys. Thank you for listening.